Good evening, everyone, and welcome to Research CP Dystonia Edition, webinar number 2. We're going to wait a couple minutes before we get started. I'm just starting this minute before the hour of 8 p.m. Eastern time, so we'll just sit in quiet meditation, let a few more people join, and then we will get going. One or two more minutes and we'll start the program. Okay, I think we'll get going. So once again, good evening, everyone, and welcome to Research CP Dystonia Edition webinar number 2, a care pathway for dystonia and cerebral palsy. I'm very excited to have with us tonight one of our co-organizers, Dr. Darcy Fehlings from the University of Toronto, professor of pediatrics there, and also from Holland-Bloorview Kids Rehabilitation Hospital. I also have online with me Michelle Schusterman, who's the president of CP Now and co-organizer of this webinar series and process overall. I'd like to start by just giving you a quick sense of the agenda and then just checkpoint where we are. And then I'm going to turn the mouse and microphone over to Dr. Fehlings. Let me just start by refreshing people where we are relative to this slide that we talked about last time. So Research CP is a mechanism of gathering extended community input. So people that have CP, people that are caregivers of people with CP, advocates, clinicians, therapists, researchers, getting all of them together to establish a common language for talking about research, process for collaboratively creating ideas and generating research questions and voting on them, and then a process to winnow that down to a final research agenda that we will then publish. And then not only will we publish it, we will advocate within the community and within our research network to generate research questions generate research studies to answer those most important questions. We're in that first phase under webinars. Our first webinar was 2 weeks ago, and we did an overview and the definitions of dystonia. That webinar is still viewable online, so you can go to CPRN and look up Research CP under our research, and you'll be able to go and view that webinar if you've not viewed it yet. Tonight, we're here at webinar number 2, which is a care pathway for dystonia and CP. And then next week, we have Dr. Michael Kruer, who will be presenting current research and gaps in research for dystonia and CP. After we get through the webinars at the end of next week, shortly after that, we will start our collaborative idea generation process and our voting and refinement process. If you're listening to the webinar and you haven't signed up specifically for Research CP on MyCP, there will be follow-on emails to remind you to do that. You have to view the webinars, take a post-webinar survey, and to be invited to participate in the agenda setting process. So that's where we are. Before I turn it over to Darcy, I'll just let you know that Dr. Fehlings is going to present for 30 to 40 minutes, and then we're going to go into an open Q&A period. When we get to that slide, I'll give a little overview about how that's going to proceed. So with that, I am going to confirm that I can hand mouse control over to Dr. Fehlings. Darcy, you want to see, I see the mouse moving, so that's a good sign.
Good, I've got control. Good evening, everybody. And if you're over in Australia or New Zealand and listening, good day. I'm really pleased to be talking about dystonia in cerebral palsy this evening. I am a developmental pediatrician, and I run a large hypertonia management program at Holland Bloorview. And one of the most challenging things that I find is really managing dystonia and pain associated with dystonia and cerebral palsy. So tonight we're going to talk about a tool called the Hypertonia Assessment Tool, which can help give clinicians something to add into their neurologic examination so that they're not missing dystonia. And then we'll spend the bulk of the time talking about approaches to management of dystonia with a bit of a focus on medication and pharmacologic and neurosurgical interventions. So we reviewed in the last webinar some of the hallmark features of dystonia. And one of the things that we highlighted was that dystonia is both an involuntary movement disorder and a cause of hypertonia. So individuals with dystonia and cerebral palsy, they can present with movements that they're not able to suppress, but also commonly they can present with stiffness in their muscles. And that stiffness is sometimes misdiagnosed as spasticity, where when we do a neurologic examination, we're actually able to detect dystonia. So another hallmark feature of dystonia is the tone is very variable. So it can fluctuate through the day and the evening. And there can be things that trigger dystonia. So when a person tries to move, that's a common trigger for dystonia. Or if a person is excited or feeling unwell, that's also a trigger for an increase in tone from dystonia. And sometimes just touching the individual, if they have dystonia, can trigger the dystonia. There's stiff movements, and for people who have a lot of dystonia, they can get stuck in postures. And these postures are often twisting in nature. So the neck can be turned, or the head can be turned to the side, the body can be twisting, or the arms and legs can be twisting. And sometimes we even see that the eyes are twisting. So why do we treat dystonia and cerebral palsy? I've put a question mark here around improving motor function, and certainly for our oral medications and some of our pharmacologic and neurosurgical treatments, I don't think we see a big improvement in motor function. We sometimes can see an improvement in motor function with some focused motor therapies. But when we're looking at medications and pharmacologic treatments, often we're aiming to relieve the pain associated with dystonia or decrease tone for the individuals to make them more comfortable and facilitate ease of care or comfort during activities like getting dressed. I've put this slide up. It's a study that we published in Pediatrics, which is a Journal of Pediatrics, which is one of our pediatric journals. And we looked at characterizing pain in children and youth with cerebral palsy. And I've got a blue arrow on the purple and the yellow, which represents moderate to severe pain that's limiting activity. And we can see that in this particular study, that the presence of dystonia or the presence of hip subluxation were the common causes for moderate to severe pain. And increasingly, clinicians are really recognizing, and I think families already know this, that dystonia and pain can go hand in hand. And when we have chronic pain from dystonia, that obviously can be quite distressing for the individual and lead to consequences. I mentioned earlier that sometimes the dystonia is missed in the labeling of the subtype of cerebral palsy. And that's really important for a few reasons. One of the reasons is a clinical reason, is that if we know that there's dystonia, it guides our treatment in different ways. So there's different medications that we'll use for dystonia. And another example of why it might be important clinically is with our orthopedic surgeons, when they go to do surgery, they approach muscles that are dystonic a little bit different than muscles that are spastic. It can lead to a little bit more complicated post-operative course, and also a little bit more challenges assessing the length of the muscle and the length that the muscle needs to be. The other really important reason that I think it's really important to clearly delineate dystonia is in much of our research that's published in individuals with cerebral palsy. I think we could be doing a better job of describing the individuals that are participating in these research studies because we think that individuals with dystonia may respond a little bit differently to treatment than individuals with spasticity. So if we don't have a clear marker for the dystonia, it's hard for us to figure that confounding variable out. So for many of those reasons, a group of us in the Childhood Motor Task Group that formed in early 2000 decided that it was a priority to develop a tool that would help clinicians not miss dystonia. And we called it the Hypertonia Assessment Tool. And I'm just going to tell you a very little bit about it today. So for those of you who want to learn more about the HAT tool, we have developed an educational tutorial. And these slides will be available linked into the webinar after we close the webinar. And so if you want to go onto the site, it'll go over the Hypertonia Assessment Tool administration in much more detail. And there's some videos that we've downloaded. We've got a scoring chart, which I'll show as well. So the nice things about the HAT is it really is a tool that can be integrated into the clinic quite easily. It takes about 5 minutes to administer. It's been developed for children, so between 4 to 19 years of age, but there's no reason that the HAT tool couldn't also be used for adults with dystonia and cerebral palsy. And it focuses on the different type of tone. There is spasticity, there's dystonia, and very, very rarely there's rigidity. And so what the hat tool allows you to do is differentiate dystonia from spasticity. I'm just going to move to the next slide, which shows us the scoring sheet. And you'll see that there's 3 different colors here. So the blue colors are the maneuvers that we would do if we were looking for spasticity. So what we do when we're looking for these blue items is we need to stretch the arm or the leg in a slow manner and in a fast manner. And when we stretch it fast, we get more tone and resistance, and we get a catch that happens as we stretch the muscle, and we can feel that. Increased tone with increased speed of stretch only happens with spasticity. So what that tells us as a clinician is we need to stretch the muscle slowly, and we need to stretch the muscle quickly to determine if there's this velocity dependent tone. The orange items, there's 3 items here, they represent our dystonia items, and the green items, which we're going to ignore tonight, are our rigidity items, and we're going to ignore them because they're very uncommon in individuals with cerebral palsy. So going back to the orange salmon-colored items for dystonia, we're really utilizing the things that we talked about before in terms of the characteristics of dystonia, and then we're looking for those characteristics in a standardized way in our neurologic examination. So the first one talks about increased movements or postures when we do tactile stimulus. So tactile stimulus just means when we touch a limb. So say we were looking at the right arm and there was stiffness in the right arm, then what we might do as a clinician is touch the left arm very gently, just rub up and down the forearm, but we would be looking at the right arm and we would see if that triggered increased movement or posture of the right arm. So you might see the elbow go into more flexion or extension, and you might see the forearm or even the shoulder rotating, often inwards with the tactile stimulus. We can see similar types of movements in the legs. The second item is looking for these increased involuntary movements or postures when the person is trying to move. So again, this is using the concept that when we try to move our body and we have dystonia, it causes us to stiffen up. And so again, if I use our right arm as an example, what we might do is we'd say, just keep your right arm still, and we would get the person to open and close their left hand or move their elbow back and forth. Or some people might have trouble voluntarily moving their arm. We could ask them to open and close their eyes. And then what we're looking for is whether that voluntary movement triggers involuntary movements in the right arm in this case, or postures. And then finally, the third item that we can screen for dystonia with is this, again, this concept that you're going to get increased tone or stiffness when you move the body part. So again, if we use the right arm as an example, with the person at rest, we would move the elbow into flexion and extension and feel what the arm felt like at rest. And then we would get the individual to do a voluntary movement in another body part. So for example, opening and closing their eyes. And then we would move the elbow again while they were opening and closing their eyes. And if they had dystonia, then that stiffness would potentially increase. So although the hat tool sounds very fancy, you can see that I've been able to describe the things that we can do and build into our neurologic examination in a fairly simple, straightforward way. And the trick really is to remember to do both the spasticity and the dystonia items to determine if a person has stiffness because they have spasticity, or they have stiffness because they have dystonia, or they might have mixed tone, both spasticity and dystonia. So that's all I'm going to say on the Hypertonia assessment tool for now, but when we get to the end of the webinar, I'd be really happy to answer any questions about it as well. And as I mentioned, we've given you a link in the slide deck so that if you want to explore a little bit more about the administration for the hat and look at some videos so that you can see with videos how we're doing these maneuvers, you'll be able to link in, and it's a website that's open access. I mentioned right at the beginning of the talk that I really wish we had a lot better treatments for dystonia and cerebral palsy, but these are the mainstay of treatments that we could potentially utilize. Rehabilitation treatments, oral medications, botulinum toxin, intrathecal baclofen, and deep brain stimulation. So I'm going to talk a little bit more about these treatment options. Before we go into that though, I'm going to turn the webinar over to Michelle Schusterman, who you heard was one of our co-organizers, and she's going to share a little bit about Lillys story with us. Over to you, Michelle.
Thank you, Darcy. Can everyone hear me?
I can hear you well.
Okay, great.
Everyone can hear you.
So I'm going to speak on behalf of my daughter, Lily, who's 12 years old, and she has a mixed form or a mixed presentation of cerebral palsy with spasticity and dystonia. And she and I sat together, and she told me what she wanted to share with all of you. She was diagnosed with dystonic posturing when she was 3 years old. We actually had visited a clinic outside of our area. They had a CP clinic, and at the time, I remember, taking note of that information, but I didn't get the so what, meaning that I understood that she had something called dystonia. I didn't know what the implications for that would be. And it seems that only now I'm really understanding that as she's gotten older. So getting information to families and individuals with cerebral palsy about what it means to actually have dystonia and the implications for that are extremely helpful. Lily had said to me that she wished she knew sooner how dystonia affected the way she moves. And that's very true, because what was challenging for us is we kept trying to address what we thought were issues with spasticity. And she has some functional movements that are impacted. And one of them that she often will discuss is that her legs and feet don't stay on her wheelchair foot plate. And it was almost all day long, and has been all day long, that all of us would try to constantly adjust her feet because they would pop out of her chair. And then when that would happen, her posture for her entire body would get disturbed. So that was from dystonia. And I only learned that was from dystonia because I happened to be at a conference where I was participating as a representative for the community as a consumer, and some clinicians saw video of her and her discussing this frustration, and a couple of them came over to me and said, that's from dystonia, right? And I didn't. So that was actually just a year ago. So it's taken a long time to gather all of this information to truly understand how these movement disorders present themselves. And so Lily, this is very interesting. So she's the kind of child that likes as much information as possible. And she's still quite young, but she wanted to know if there was a dystonia scale. And she'd like to know how severe her dystonia is, because she wants to know that information so that in the future, if there are ways that she can address problems with her body or have a better understanding of how her body is working or not working, she feels that this would be helpful. So she said her main concern was that she really wants researchers to figure out how to make her CP symptoms go away. And those were her words. They were quite difficult for me to hear as her mother, but I wanted to be authentic and share them the way that she wanted to share them with all of you. So, and I think in her mind, it's not pain associated with dystonia that is a problem for her. It is the functional limitations that go along with it. So that is my daughter Lilly's story.
Thank you so much, Michelle, for sharing that. And it's great to hear the questions that Lilly wants us to focus on. And I know that we'll come back to discussing some of those questions towards the end of the summary of the care pathway. So thanks so much for sharing that, Michelle.
Sure.
So, Paul, if I don't know if my screen is freezing a little bit. If you could advance the next slide, or
yeah, let me see. I hear it beeping. Let me see if I can figure out what's going on from that. So there's the advancement. But will you see if you have control now to go back and forth, though?
Sure. Yeah, looks like
You
I do.
Okay,
Thanks,
great.
Paul. That's great.
No worries.
So I mentioned at the beginning that many clinicians are quite challenged by managing dystonia. And sometimes we're having trouble diagnosing the dystonia. And then it's a complicated management. And because of the complexity, we decided a subgroup through the American Academy for Cerebral Palsy and Developmental Medicine, which is what the AACPDM stands for, decided to create a care pathway for dystonia in cerebral palsy. And again, the slide deck will be made available. And if we have time at the very end, we'll see if we can go on to the site. But this site is also an open access site, and is something that you can link into and explore. So when you go on to the American Academy homepage, you'll see a little area here called the care pathways. There's these little stones that are going off into the horizon, and you can link on those. And then there's a few different pathways, but you'll see that there's one on dystonia and cerebral palsy. And all the pathways are organized the same way. So they've got these 3 sections. And I think all 3 sections are helpful, but section 1 is probably the one that's the most helpful. So it's called an evidence summary or a bottom line summary. And it provides a 5-minute read on dystonia, why it's important, and what some of the different treatment options are for treating dystonia. And then there's also been a detailed review of the evidence to help to guide our knowledge of what we know about the different treatments for dystonia and cerebral palsy. And I'll show you what that picture looks like, but you can utilize it to see how we might, as clinicians, go through decisions around what we might consider recommending for dystonia. In section 2, for those of you who like to have a deeper read, if you open section 2, there is a article that in this case has been published in Developmental Medicine Child Neurology that does a deeper dive into the evidence around medications and surgical treatments for dystonia. And then in section 3, it's called Practical Tools. there's a few different practical tools in section 3. So for our dystonia care pathway, there is a lay summary, a paragraph just summarizing what dystonia is and why it's important, and a brief overview of the different types of treatment. There's also a link to the Hypertonia assessment tool, the educational tutorial that I was speaking about, and a few other practical tools. So let's look in a little bit more detail into section 1. So I am a visual learner, and so I always like having a figure to look at. And this represents the top of the figure in the care pathway for dystonia. And you'll see here we're talking about assessment. So the first point that we're making is that you need to determine if dystonia is present. And we've already talked about the Hypertonia assessment tool and the neurologic examination. And the other thing you're going to look for is if the tone is generalized, so lots of muscles that are stiff, or if there's just a few muscles that are stiff, because that's going to affect how we might approach treatment. You can assess the severity of dystonia by history, asking questions about how the stiffness is impacting the person with dystonia. And then on our neurologic examination, we can feel and rate how stiff the muscles are by using a tool called the modified Ashworth score. And we also use something called the Berry-Albright dystonia, or the Burke-von-Marsden scale, to rate the severity of dystonia. And if people are interested in that, we can talk a little bit more about that at the end. One of the really important things that you want your physician to do is really to do assessment of whether the dystonia is consistent with cerebral palsy. So there are other reasons that you can have dystonia, and we want to make sure that we have a diagnosis of cerebral palsy. We want to be looking to see if there's anything that we need to rule out if we have dystonia. So we look at the potential risk factors for cerebral palsy, and we also take a look at the picture of the brain. Sometimes when we have dystonia and cerebral palsy, we'll see an injury to areas of the brain in the basal ganglia. If we think that dystonia is there and it isn't cerebral palsy, it'd be important to refer to a neurologist who has a lot of specialization and expertise in figuring out differential diagnoses. And one of the things that that neurologist might do is they might give a trial of a medication called levodopa to see if the dystonia improves with that. And sometimes if we see a big improvement with the levodopa, it means that we need to be considering other things besides cerebral palsy causing the dystonia. In the assessment, we also want to assess the impact of dystonia on the individual's function and also their quality of life. So I put some stars in so that you can see which area I'm going to focus on. So I've moving up to this circle here. So when we have dystonia and cerebral palsy, one of the things we know when we have significant dystonia is that if you have other health problems, it can really trigger the dystonia. So some really common triggers that make dystonia worse are if we have acid reflux and we have pain from the acid reflux, that can trigger more dystonia. Another really common one for the children I see is when they are constipated and they're uncomfortable from being constipated, that can make dystonia worse. If we're having problems sleeping, we don't get a good night's sleep, that can make dystonia worse. So we really want to look at if there's any health issues that are impacting that we can improve by directly looking at those health issues. I'm moving to the other circle on the other side of the square, which is periodic reevaluation of dystonia. And the important point I want to make here is that dystonia really fluctuates over time. So it can have periods where it's quite good, and then periods where you get a lot more stiffness. And because of this fluctuation, you really benefit from having a healthcare team that works with you over time. And so if the dystonia is getting worse, the team can help to figure out what more management you may need, or if the dystonia is getting better, maybe there's some medications that we can take off. Oh, looks like, oh, there we go. And I've already talked about that star. So the final box here is determining if there are goals for intervening for dystonia. So the common goals where we're looking at managing dystonia are if dystonia is causing pain. That's a really important one to really try to treat the dystonia to get the pain under control. And then if the dystonia is interfering with function, then those are the two common reasons for treating dystonia. All right, so this is going down the picture that is in the care pathway. And you'll see that the first step we have is introducing rehabilitation strategies. Maybe another point that I'll make here before I talk about some of these areas in detail is you'll see that there's different colors now for the interventions. And currently the care pathways have 3 different colors. We're about to transition to a different type of system called grade. But right now, the 3 different colors are when we have lots of evidence, we're going to color code the care pathway green. It means that we've got lots of evidence to support that it works. And then yellow is when we have in-between evidence, some probable or possible effectiveness. And then purple right now means that the data is inadequate, but the international expert panel that's come together has looked at the evidence and also carried their experience to put recommendations or considerations for different treatments. So you'll see here that there's a lot of room for some more research, and we're going to come back to that. But a lot of our care pathway currently, the data is really inadequate to guide a lot of the decisions. We've got a lot of purple there. And it's the more invasive treatments where we have a little bit more evidence. So going back to the very top of this diagram, I said, let's introduce some rehabilitation strategies. And this is something that we really recommend for all individuals with dystonia and cerebral palsy. So having a physio-occupational therapy consultation, perhaps a speech and language consultation to assess if there are therapeutic treatments or equipment that could be helpful. One of the things that's really important for an individual with dystonia and cerebral palsy, if they have a more severe physical disability, is really getting a good seating and positioning in place. When we sit forward and we're flexed forward at the hips, it can, and our trunk is supported when we have dystonia and cerebral palsy. That really helps many individuals with dystonia and cerebral palsy to feel comfortable with their tone. And there may or may not be splinting options that you would consider. We've said assess splinting options because sometimes when you have really severe dystonia, wearing a splint and tolerating a splint can be a challenge. After you've looked at rehab strategies, what you want to do as a clinician and also an individual and a family, is decide whether you have a lot of stiff muscles, we call that generalized dystonia, or just a few stiff muscles, and we call that focal dystonia. And if there's a lot of dystonia, we're going to go down the generalized dystonia route, which consists of considering oral medications. If you just have a few stiff muscles, you may want to consider botulinum toxin. So we've talked about rehab strategies, and now we're going to talk about oral medications. So there are quite a few medications that we might consider if we have dystonia. And when I'm talking with individuals with dystonia and their families, I say many of the medications work, they take the edge off dystonia, but I give them a 4 out of 10 in terms of how well they work. They often work enough to make a difference, but they don't often completely take the dystonia away. So one of the medications that many of us use as a first-line treatment is a medication called baclofen. And baclofen can help to reduce the dystonia and can sometimes help to reduce the pain associated with dystonia. And it is relatively well tolerated as long as you start it slowly. So when we're looking at the potential benefits and side effects, it often is a medication that we can consider, and many of us will start it first. Another medicine that we can use is something called trihexyphenidyl. The brand name for that is more commonly known as Artane. And we put it here as second line, but I do want to make a comment that many adult physicians will use Artane or trihexyphenidyl first with dystonia. I'd say many pediatricians, clinicians treating children would use baclofen first, but either one might be a good first-line medication to start. And then we've got some special indication medications. So if you have a lot of pain with dystonia, some clinicians are considering a medicine called gabapentin. When there are periods where you get really stiff and very uncomfortable and so stiff that you really need extra management, we sometimes call this status dystonicus. It means we're really stuck in a posture and we're having trouble relaxing. And we're getting to the point where if we were to do a blood test, we might see some muscle enzymes going up because the muscles are so stiff. They're having a small injury from being so stiff all the time. Then we might consider a medication in the Valium type medication options, and we call those benzodiazepines. And then another medication that can be helpful is clonidine. And then finally, if you have an individual dystonia is having a lot of trouble sleeping, then also considering clonidine or the benzodiazepines can be an option. I'm going to go back. So let's move on to just some general comments on oral medications. So they certainly have a potential role in generalized dystonia, but if a person only has a few muscles, I won't use an oral medication. We usually will use something like botulinum toxin, and we're going to talk a little bit about that. There's a lot of variability amongst healthcare providers in the type of oral medications that they're using. And I think the cause of the variability is that all of the medications sort of work medium well, and we have to watch out for side effects. And we really do need more evidence to guide our practice. We have minimal information on the long-term learning side effects of the oral medications, and it's certainly something that I worry about when we look at starting oral medications, because often we're looking at starting medications over a long period of time. It's not like when we're taking antibiotics and we're just going to be on them for 7 days or 10 days. And so we really need to carefully discuss and work with the individual with dystonia and cerebral palsy to try to explore the proportionality of treatment, the potential benefits and the potential side effects, and where that balance lies. And then in the care pathway, for oral medications, really leaning towards individuals with severe generalized dystonia, where dystonia is causing some sort of pain or sleep disturbance or a real challenge in aspect of the individual's daily living. All right, so let's move to the focal dystonia. So I put a little blue star beside botulinum toxin. And the botulinum toxin is a medicine that we can inject into muscles that are stiff. And the way it works is it blocks that message of stiffness coming from the brain, but it blocks it where the nerve meets the muscle. And if we have a few muscles that are stiff, then we can inject botulinum toxin into the muscles, and it causes a temporary relaxation of the muscles for about 2 to 3 months. For clinicians who are listening to the webinar, one of the things to be cautious about when using botulinum toxin with dystonia is we often have stiffness on both sides of the joint. So again, if I use my right elbow as an example, and the person is really stuck with their elbow extended, we might consider injecting behind the elbow in the triceps muscle, but we'd also put a little bit in the front of the elbow in the biceps to balance out the effect, because often the dystonia is in both sides of the muscles. And if we just injected one side, we might then move to a posture that is stuck in the opposite way. So if we started with the elbow extended and we just injected the triceps, the individual might then move to their elbow being persistently flexed. So in contrast, in individuals with spasticity, when we have dystonia, we often inject on both sides of the muscles around the joint. When we have spasticity, we often just inject in the muscles that are the most spastic. Botulinum toxin can work quite well to reduce dystonia, and can also work well to reduce the pain associated with dystonia. And then one of the disadvantages is that if it's working really well, it often wears off after 2 to 3 months, and then you often need to consider another round of injections. And particularly if you're a child, but I'm sure if you're an adult as well, getting needles every 3 months is not so much fun. As we move down the diagram, we're looking at more invasive, stronger treatments for dystonia. And I put a blue star beside intrathecal baclofen. And this is a treatment that can help people who have a lot of stiffness in their muscles, where their muscles are so stiff, they're really uncomfortable, and it makes it very hard to get dressed, to get the legs separated, or the legs may be flexed or stiff, and it's very hard to get dressed. So what is intrathecal baclofen? We've got a little picture here of a pump that looks like a hockey puck. And inside this puck is a reservoir that can hold liquid baclofen. And a surgeon puts it in under the skin and creates a little pocket under the muscles of the abdomen, in the front of the abdomen. And then there's a catheter that goes from the pump and tunnels into the spine and is placed in the fluid around the spine, and then the surgeon feeds the catheter up. And so the tip of the catheter can sit anywhere here in the thoracic region, and sometimes up into the cervical region when we have dystonia. The pump has a little motor, and it pumps minute amounts of liquid baclofen into the spinal fluid. And then the baclofen interacts with a receptor that's sitting right on the dorsal surface of the spinal cord, and that can help to reduce tone. We are still trying to understand the complete mechanism of how intrathecal baclofen works for dystonia. We think there also may be some central carrying of the liquid up into the fluid-filled spaces up in the brain, and it may also have actions up higher. So intrathecal baclofen is strong and can help to reduce tone in a stronger manner than oral baclofen. So it's a little bit more effective at reducing tone, but it does come with some potential side effects. And one of the side effects is that when we're using the intrathecal baclofen and we're blocking those receptors with baclofen, if there's any interruption in the baclofen supply, the person can get really stiff. And that can lead to a medical emergency because the stiffness can get quite bad. So what are the common causes of the baclofen supply being decreased? And one of the common causes is the weak link in the intrathecal baclofen is the catheter here. So they've made lots of improvements in the catheters over the last decade, but as it traverses the spine and enters the intrathecal baclofen, there can be a little bit of pressure that acts on the catheter here. And then the other area that there can be a little bit of stress on the catheter is here where it attaches to the pump. So lots of improvement in the catheter, but you can sometimes get a little micro hole, and it's that little very small hole is strong enough for the dystonia to drip out and cause increased stiffness. Now this can be treated, and the surgeon can go in and replace the catheter without having to replace the pump. So there are treatments for it, but it is a medical emergency. And so people with intrathecal baclofen pumps always have to be close to healthcare providers that know how to manage the intrathecal baclofen. I'm going to take a little pause in my speaking and turn it back now to Michelle, who's going to talk a little bit about Evander's story. So Michelle, over to you.
Thank you. So this is Evander, and I'm going to speak on behalf of the family and his mom, Jennifer. He was diagnosed at between ages 2 and 3 by a physical medicine doctor with having dystonia, and he's now followed by a neurologist who specializes in movement disorders. Jennifer said that he has dystonia all over his body, but it's worst in the head and neck area. And he currently is taking baclofen for his dystonia. They were offered botulinum toxin, but they have not tried it. And Jennifer said her primary concern was if the dystonia is causing his scoliosis to progress more quickly and causing other problems with his physical anatomy. And she's interested in deep brain stimulation, and she wonders if that's something that could potentially help him and address some of these symptoms.
Thanks, Michelle. So that's a really nice segue into the other treatment option we have when we have really severe generalized dystonia, and that's called deep brain stimulation. And deep brain stimulation is where a neurosurgeon would put a very, very small wire deep into the brain, into an area of the brain called the globus pallidus. And then they connect it underneath the skin to a little stimulator that sits under the skin in the upper chest area. And the stimulator provides small electrical pulses. And for some individuals with dystonia and cerebral palsy, it can help to relieve dystonia. So it is a treatment that has been around a long time for adults with Parkinson's disorder. And then when we have dystonia for other reasons, so some of our genetic dystonias, Neurosurgeons and neurologists have been using deep brain stimulation for a longer period of time. And then with the success with those neurologic conditions, there was a movement to look to see whether it might be helpful for individuals with dystonia and cerebral palsy. And so we're getting increased numbers of individuals with cerebral palsy with dystonia trying deep brain stimulation. And there is some probable evidence that it can be helpful in terms of reducing dystonia. It's at the moderate level when we look at what the average response is, but some people respond more than others. And it's really hard to predict ahead of time who's going to respond and have a really good response to the deep brain stimulation and who may have a more modest response. But certainly there's a lot of interest in deep brain stimulation. And we put it at a similar level as the intrathecal baclofen, so something to consider. There's a lot, again, of variability in terms of clinicians who might recommend deep brain stimulation versus intrathecal baclofen. Some of the considerations that we have here in Toronto is if an individual with cerebral palsy has both spasticity and dystonia, then we might consider intrathecal baclofen because it can help both with spasticity and dystonia. But if a person only has dystonia, then we might lean towards deep brain stimulation, which can help dystonia but doesn't improve spasticity. Some people prefer the deep brain stimulation because they don't need to go for baclofen refills every 3 months, and there isn't that risk of going into baclofen withdrawal. So there's some advantages and disadvantages to each of the more invasive treatments, and it's certainly a specialized clinic that you would want to go to for consultation to help discern which treatment might be a potential option for you if you have a lot of dystonia. So moving to, in conclusion, dystonia is a frequent cause of hypertonia. It's often missed, and I'd say we're making some headway in the last 5 years, but we've still got a ways to go to really help build clinicians' capacity to diagnose dystonia. It's a frequent cause of pain in individuals with cerebral palsy. So if I have a child that comes in to see me in clinic and they're in a lot of pain, I really look carefully for if they have dystonia. They can go together quite frequently. We talked earlier on about the Hypertonia assessment tool, and it's helpful in detecting dystonia in the clinic, but I'd say it's underutilized. And then we had a chance to go over the care pathway in a fair amount of detail today. And I think one of the themes that you can see is that the majority of our treatments for dystonia, it would benefit to have more evidence to help inform our practice. So Paul, at this point, I may turn it over to you and see if you want to open up for questions. I know we're getting close to 9 o'clock and I don't want to cut the questions short. I would invite people to go onto the Pathway site and explore it themselves and give us some feedback if you have questions. We're always interested in hearing some feedback. So Paul, I'll turn it over to you for questions.
Great, Darcy. Thank you so much for your very thoughtful and meaningful presentation. I think it'll be valued highly by everyone in the community. We want to run Q&A a little bit differently this time. So first of all, managing the sort of people raising their hands versus people writing in questions is a bit challenging. So I'm going to ask that the primary way we'd like people to submit questions is to go to the question dialogue that is on your sort of control panel there, and and enter enter your questions there, and and I'll take them. I'll summarize them to Dr. Fehlings and let her answer them. If writing a question is a barrier to you and you prefer to speak your question, ask your question, you are welcome to raise your hand, and I will try to keep an eye on both hand raises as well as questions coming in through the polls. But this will give us a little bit easier way to manage it, I do believe. With that, I'm going to open it to questions, and I think we have a first question. Okay, well, the first person that has a question would like to ask it, so I'm going to ask that you type it in, unless you, if you need to raise your hand, feel free to raise your hand if you can't type it in, and I will get you there. So hold on one second, managing my two lists of things here. Okay, got to open that up here, pull it out here. Oh boy, we have a lot of questions. Okay, all right. Okay, can you touch on the difference between spasticity and dystonia? I feel like in what has been explained to me by clinicians, that would be very similar. And I know you talked about this. So Brenna, if you feel like your question is still unanswered, feel free to just shoot me a chat and I will know that. But could you distinguish again, Darcy?
Yes, absolutely. So for spasticity, what the individual might report is that the spasticity is fairly constant. There isn't a lot of fluctuation. There's still stiffness in the muscle, and that spasticity more predictably will cause the muscle to go into a certain posture. So what do I mean by that? If we look at the arms, often if you have cerebral palsy involving your arms and you have spasticity in your arms, a really common pattern is for your elbow flexors to be stiff. And so you might hold your arms flexed at the elbows more. But it would be fairly consistent and your elbows would stay generally flexed. Versus if you had dystonia in your arms, you may experience a significant fluctuation or change in your tone, and certain triggers might trigger your dystonia. So at times your elbows might be flexed, but at other times your elbows might be stuck in extension. And then the other thing that I'll comment on as it relates to differentiating spasticity and dystonia is that dystonia, when you're really stuck in a posture, you can feel some pain. You can still have some pain or discomfort with spasticity, but it tends to be a little bit less severe than with dystonia.
Great. Moving right along, if you have a patient that does not respond when asked to make a specific movement, like keep your arm still and move the other hand, how do you apply the hat?
Yeah, that's a really great question. And so as a clinician, what you want to do is you want to assess what that individual's abilities are to voluntarily move their muscles. So we have a range of movements that we've outlined, and if you want to read more about it, please go on to the tutorial. But we often start with hand opening and closing, or elbow flexing and extending. But if the person isn't able to do that, we can ask if they can open and close their eyes, or move their tongue out, in and out of their mouth. And then finally, if the person is fairly trapped in their body, we can do a voluntary movement where we get them to track a light. And then the voluntary movement of moving the eyes is something that many individuals can do, even if they're having trouble moving their limbs. So we do recognize in the hat that there's a variability in people's abilities to move their muscles. And so we have suggested these range of options, and we haven't limited you to one or two. You can work with the individual to see what they can do. One of the things that's important though when you're doing the hat is it should be a movement in the body in another area than what you're assessing. So if I'm assessing the right arm, then you're going to look for movements of the head and neck, or movements of the left arm, or movements of the legs. But you want them to try to keep their right arm at rest.
Great. Another question was, I've never heard of I don't know, I may be pronouncing this wrong, levodopa. Is it similar to Cinemet or Artane?
Yes, it's the commonest brand name is Cinemet, and Cinemet consists of levodopa and carbidopa, and it's the levodopa that is the therapeutic aspect of Cinemet, and the carbidopa just helps to balance the levodopa and manage some of the side effects. So it's commonly known as Cinemet. We try to use the generic names when we're talking about the medicines, so that's why we're saying levodopa. Artane is different. Yeah, Artane is different.
Go ahead.
The generic name for Artane is trihexyphenidyl, and it has a different mechanism of action. I didn't go into a lot of the mechanisms of action, but it is a different a class of medication.
Okay, and I'm going to ask one more follow-on to this, and then I'm going to skip over some of your questions, Melanie, just to share the questioning floor. It seems that many children have a difficult time tolerating Artane. Why do you think this is?
Sometimes when we start a medication, we start it too quickly. And so for all the medications, but particularly for baclofen and Artane, I start on quite low doses and then just very gradually work up. So unless there's a really big reason to increase quickly, I sometimes will start once a day and keep them on a once a day dose for a week, and then gradually increase to twice a day, and gradually increase to 3 times a day. So it may be that you're going up too fast. The other thing with Artane is that I find that baclofen is just a little bit more tolerated than Artane, so the side effect profile seems to be a little bit easier to take with the baclofen, as long as you don't go up on the baclofen too quickly. I have a bit of a bias in my pediatric practice that I used to have trihexyphenidyl or Artane as my first line, but I just was finding that I wasn't getting as good a response as the oral baclofen. So over time, I've transitioned to oral baclofen being a first line. I just find that for more kids, it tends to work a little bit better. But in saying that, there are some children that do respond well to Artane, and it's certainly a medication that's in my dystonia repertoire. Yeah.
Okay. I'm gonna give the microphone to someone. Amanda, I want to let you know one of the things I didn't say is one of the things that we need to be careful about. I don't know what your question is, but the clinicians can't answer sort of specific questions about people and their cases. So if you have a generalized question, a question that generalizes to other audiences, feel free to ask. I'm going to take you off mute for a second and let you ask your question, but please keep that, and for others to keep that limitation in mind about the questions that Dr. Fehlings can answer.
Yes, hi,
So
Dr.
Amanda,
Fehlings.
you should be able to speak now.
Okay, hi everyone,
Go ahead.
Dr. Fehlings. This is Manda Kripanmestic, mother of 6-year-old mixed dyskinetic CP. So my question is, for you as your role in kind of, like a leadership role at your facilities where you're working, are you able to, like, I'm noticing a lot of times that all these CP studies, like I found 2 of them this week specifically, my daughter's potentially excluded because she has the mixed dyskinetic. And a lot of these studies are looking for specifically spastic studies. Is there any way that, in talking to your peers and your colleagues, that you can sometimes ask them to expand the parameters? Because just this week we were told, oh, your daughter, she, we'll do another study and she can be included. Well, if you have mixed dyskinetic, you're less than 15% of the population that has a specific type of CP. So most likely there won't be many studies. And I know this is what we're here to do, but is there, in your capacity, are you able to ask clinicians to expand their parameters? Like, I know there's a very large one coming out of your organization specifically about metformin, where I know I can't go into details, but just to expand the parameters to include children like my daughter and other children, because it could be potentially many, many years where specific studies are for children of dystonia, whereas they could be, like a sub-study of other CP studies.
Yes, I think you raise absolutely really, really valid points. So one of the things that I'd like to cycle back to is that when we are looking at our evidence for cerebral palsy, we really haven't characterized the individuals that are involved in the studies very well. And so you mentioned mixed cerebral palsy, where you have both spasticity and dystonia, and we've shown in studies that 75% of individuals with cerebral palsy have mixed tonal patterns with spasticity and dystonia. So it's a very common thing in cerebral palsy. And I do think it's a variable that can impact or interact with the intervention that's being tested in the research. And so having a characterization of your subjects and whether they have exclusively dystonia, exclusively spasticity, or mixed tone, I think is really important. So in some of the secondary analysis in the study, you can actually look for that interaction with the treatment. And it may be that individuals with dystonia are responding better, or individuals with mixed tone are responding better than individuals with just one type. But unless you have that marker at the beginning, it's really hard to assess for that. And you certainly don't have to. I am a huge believer in the need for better dystonia treatments and research, and I think it's really critically important. So I say to many of the individuals that we treat in clinic that if I had anything that I could wish we could treat better, it would be dystonia. And so we really need to drive that forward with research. So it is important to have research for individuals with dystonia and cerebral palsy. I really agree with that. And you briefly mentioned a metformin study, and this is a study where the underlying background information suggests that it is going to be more effective for individuals with spasticity. But in our criteria, we are allowing mixed tonal patterns. So again, recognizing that many individuals with cerebral palsy have mixed tone.
Thank you. Thank you for answering that.
Okay.
Okay, and just so everyone knows that Dr. Fehlings agreed to be able to go to 9:15 East Coast time. So this is probably going to be the last question unless it's very quick. So it's from Poonam. Your question is, sometimes we see twitching of the muscles in the muscle in the legs, especially in the legs. Is that related to dystonia?
So it's hard to say without seeing the twitching and examining it. So sometimes we can get a repetitive movement at a joint that we call clonus, which is almost like a beat, and it can repeat. So if that is the type of twitching, that type of clonus is often associated with spasticity rather than dystonia. But if you have an involuntary movement disorder where you have twitching and there's a twisting element, then that certainly could be dystonia. And what we would do on our neurologic examinations, we would do some of the hypertonia assessment tool assessments to try to tease that out.
Okay. Well, so with 1 minute left, I want to say thank you so much again for your time, Dr. Fehlings. And I want to emphasize to everyone that everyone that's part of Research CP Dystonia Edition has an account on MyCP, and there's a forum there. And if the questions are general in nature, like some of these, like the next question was, the next general question was, how does brain stimulation help dystonia? Those are great questions to post in MyCP. Everyone will be able to benefit from the answers, and we will encourage Dr. Fehlings and other clinician participants in the study team for Research CP to answer those questions because of the generalized value of them. So sorry if we didn't get to your question tonight. Again, thank you very much for all of your attendance, and Dr. Fehlings, thank you so much for your great presentation. Thanks, everyone.
Thank you, Paul. Thank you, Michelle. Bye, everybody.
Bye, thank you.
Bye.